session and also introduce to us our guest speaker. Professor Akinbami, over to you, sir.
Thank you very much, my Lagos brother and friend, Dr. Letu. Thank you very much. Good afternoon, distinguished colleagues, the members of the Guild of Pediatricians in Private Practice, the chairman, who unfortunately we couldn't, because of network, we couldn't hear him. That's Dr. Mobolaji Lawal. Good afternoon, sir. Former Distinguished Pediatrician of the Year. I welcome the guest speaker also, and every other attendee here. You are all welcome to this webinar. I must say that just briefly, Senge Letu has a way of ambushing me, and when he sent the flyer, which I had seen before, to my own site, I said, okay, it's just reminding me. And I acknowledge, though I've seen it, I will attend. Only to them be sent, the real ambush that I will be moderating this. But it's with great pleasure that I accepted this because of him, because of the chairman, who we all know very well and respect, and also because the guest speaker happened to be a key member of my association. So I have come to give her moral support in case she's to be harassed by the guild. So be that as it may, the topic is an interesting one: abdominal pain in children, the current concepts, management concepts, or management of abdominal pain in children, the current concepts. It's a common complaint that pediatricians, whether in the general practice or even including physicians, do come across. It's a complaint that most children come to the clinic for. And of course, in most cases, there's very little or nothing that will be done for them. But we're not going to belabor this because we have the guest speaker who will take us through the management. So who is our guest speaker? Dr. Olufunmilayo from Adeniyi. Please, I hope you can hear me.
Loud and clear, sir.
Okay, thank you. So our guest speaker is Dr. Olufunmilayo from Adeniyi, who had an undergraduate training in the University of Ibadan and was awarded MBBS Ibadan in 1994. He then undertook her residency training at the University College Hospital Ibadan from 1997 to 2002 and obtained the fellowship of the National Postgraduate Medical College of Nigeria in pediatrics in 2002. She later attended the University of Warwick in the United Kingdom between 2005 and 2006, where she again obtained a master's degree in child health. She joined the academic staff of the University of Lagos in November 2009 as lecturer 1 and was also appointed a honorary consultant at the Department of Pediatrics, Lagos University Teaching Hospital, Idiaraba, the same year. Between 2016 and 2017, she had her subspecialty clinical training in pediatric gastroenterology, hepatology, and nutrition at the famous Tygerberg Hospital in Cape Town, affiliated to the University of Stellenbosch in Cape Town, South Africa. This was in October 2021. She also obtained a master's degree in gastroenterology at another famous institution, that's the Queen Mary's University in London. So you can see we have the most appropriate person to talk to us on this topic. So Dr. Adeniyi was promoted to associate professor in 2022, and is also the head of the pediatric gastroenterology, hepatology, and nutrition unit of LUTH. As expected, she's actively involved in undergraduate medical education and residency training in pediatrics. She has supervised several postgraduate dissertations in pediatrics and co-supervised BSc and MSc programs in other departments, particularly the Department of Pharmacy and Community Health at the University of Lagos. Dr. Adeniyi is an examiner of the National Postgraduate Medical College of Nigeria. He's a regular one, for that matter, in the Faculty of Pediatrics. She is an avid researcher who believes in collaborative work, both locally and internationally, in answering some of the questions posed by clinical sciences, especially in pediatric gastroenterology. Her research is multifaceted and covers aspects of healthcare from the laboratory bench to the community. She has, to her credit, over 40 publications published in peer-reviewed journals, both nationally and internationally. Dr. Adeniyi is a member of several learned societies. One worthy of note, and which I'm proud of, is the Nigerian Association of Pediatric Gastroenterology, Hepatology, and Nutrition, that happened to be the president. And in this association of ours, she is the current financial secretary and also an active member of the association's academic committee. Dr. Adeniyi is happily married and the family is blessed with children. So distinguished colleagues and guests, I'm happy to hand over to our guest speaker, Dr. Adeniyi. But I must say, as I've been given the rules, I think the lecture will be for 45 minutes, and after which we'll allow 15 minutes for comments, questions that you may want to ask her. So over to you, Dr. Adeniyi. Thank you very much.
Good afternoon, elders in the house, my senior colleagues, professors, doctors in the private practice, and all my other colleagues, all protocol duly observed. I want to appreciate the Pediatrics Private Practice Guild for this opportunity to give this talk, which I believe is quite topical. And I'm sure I've at some point in time come across or managed a child that has abdominal pain. And this afternoon, we are going to put heads together to deliberate and discuss on the current concepts and even the emerging diseases that we're seeing that could present with abdominal pain. I hope I'm being heard. Please, can you see my screen?
Yes, you're sharing it now.
Okay, I've tried to share my screen. I hope you can see. Okay, I'll put it on slideshow and then start off.
We can see it now.
Okay, thank you, sir. So this will be the outline of my presentation, and I will go through two cases actually of patients that presented with abdominal pain There are some unusual cases, so I just thought I should share this one rather than talk about the usual cases that we see. They are rare cases, and they presented with us during the past 2 years, and they are interesting cases. So I thought I should share them on this forum, just to let us know of the kinds of things that we can see in children that present with abdominal pain. Then we'll go on to talk about evaluating a child with acute abdominal pain, and then we'll focus on the recurrent abdominal pain, which is the one we mainly see in the pediatric practice, and we'll run through the epidemiology of recurrent abdominal pain and talk about the treatments and then the current concepts. So the first case is OO, a 9-year-old boy from Edo State who resides at Surulere, and he presented to the clinic on account of recurrent abdominal pain of 1 year duration. The pain was said to be dull in nature, non-radiating, located in the periumbilical region. On the scale of 10, the severity was about 4 to 5, and the child was having 2 episodes per day. The pain wasn't related to meals. There were no known aggravating or relieving factors, no change in bowel movements at the time of presentation. There was no evidence of GI bleeding and no extra GI manifestations. He had not been on any drugs, namely steroids or NSAIDs or herbal preparation prior to the onset of illness, and there were no urinary symptoms. But at the onset of illness, the parents volunteered that he had a history of intermittent fever, and on account of this, they took the child to a private hospital. The fever was on for about 2 weeks or so, and he was treated in their private hospital with antibiotics. And during the course of illness, before presenting to us, he had been treated for Helicobacter pylori infection about 2 or 3 times during the course of illness. However, when the abdominal pain persisted, he was asked to do an abdominal CT scan, and then he was referred to our facility for further evaluation. His past medical history was unremarkable. His genotype was AA. The other aspects of the history were unremarkable. So he was fully immunized for age. He had no delayed milestones. He was doing well in school. He was exclusively breastfed for 6 months, after which he commenced on solids and practically eats every food now. He belongs to a monogamous family and is the second of 3 children of the family. Father is a 48-year-old architect, mother is a 38-year-old businesswoman, and there was no family history of a similar illness. On examination, he was not in any obvious painful distress. He was afebrile, he wasn't pale, he was anecteric, not dehydrated. He had no significant lymphadenopathy peripherally, no finger clubbing, and there was no edema. His anthropometry seen in the slide, and his BMI was 22.8. Digestive system revealed that he had good oral hygiene, he had normal dentition, no oral ulcers. The significant findings in the abdomen just showed that he had vague tenderness in the periumbilical region. There was no palpably enlarged organ. And the other systemic examination were within normal limits. So the abdominal CT scan he brought to the clinic at that time revealed that he had thickening of the bowel loops and thickening of the walls of the colon. And on the basis of this, we started thinking of a chronic inflammatory disorder in the GI that could account or explain this thickening of the bowel and colon that he had. So we worked him for colonoscopy. He also had fecal calprotectin screening, which is a gut inflammatory marker. We examined his stools, and we did a urinalysis and did a repeat H. pylori testing. And on colonoscopy, this was what we found. He had multiple aphthous ulcers, small ulcers in the ascending colon and in the transverse colon. Multiple ulcers, and even in the area of the ileocecal valve, he had multiple exudates. And all these findings were in keeping with Crohn's disease. On the transverse colon, they had ulcers, and there were skip areas of normal mucosa. So all the findings were actually suggestive of Crohn's disease endoscopically. And when we did the histopathology of the colonic biopsies, he actually had Crohn's disease. His fecal calprotectin and the marker of gut inflammation was elevated. Normal should be about 50, and his own was 500. his Helicobacter screening was negative. And based on the pediatric Crohn's disease activity index, the severity of his illness fell into the mild disease. And so on the basis of this, we started him on exclusive enteral nutrition, which was a liquid formula. The parents were able to import this from the UK. And the formula is called IBD formula. It's basically a hydrolyzed formula that has medium chain triglycerides and is easily digestible by the gut. And this is known to be very useful for patients that have mild disease. And he had this for about 6 to 8 weeks. And then we switched to Ensure, which is a high-calorie liquid diet, also provided by our dietitians. And it made significant improvements. The abdominal pain reduced, and he was able to, attend all his activities appropriately. After 8 weeks of therapy, we repeated his fecal calprotectin, and this had dropped to 31, and it was making good improvement. So to maintain his remission, we're supposed to commence on mesalamine, which is an anti-inflammatory agent, to salicylate. But because he was doing so well, the parents opted to rather put him on gradual diet, light diet, and prefer to stay off the mesalamine. And we've been seeing him in clinic. He's been doing well. The second case is an 11-year-old boy who is of Yoruba ethnic origin and born to a Muslim parents. They reside in Ogun State. And he also presented in the clinic about 2 years ago, actually, with recurrent abdominal pain of 1 year, and he had vomiting of 3 days. Abdominal pain was initially said to be epigastric, but later became more prominent in the periumbilical region. And there were no relieving or aggravating factors, and the pain did not disturb his activities. There was no swelling in the abdomen or constipation. 3 days prior to presentation, he was vomiting, and the vomiting was said to be non-bilous, non-bloody, and contained just recently ingested meals. There were also no extra GI manifestations in this patient, and other parts of the history, and the information we got was not remarkable. He was the first of 3 children in a monogamous setting. Father was a 45-year-old civil servant and mother a 37-year-old trader. And there was also no family history of a similar condition. General condition was satisfactory on examination, and his vitals were within normal limits. The anthropometry is as shown, but he had a BMI of 15.9. The digestive system was basically within normal limits. He did not have any abdominal tenderness, and there were no palpably enlarged organs. CVS examination, respiratory, CNS examination, they were all within normal limits. So at the time we made an assessment of recurrent abdominal pain, query cause, we thought, could he have a gastritis? Could he have peptic ulcer disease? And we did the basic investigations, which we would normally do for any of our patients that come with a recurrent abdominal pain. We would check their stools for ovar and parasites, local blood, H. pylori. We would also run a full blood count, urinalysis, and abdominal scan. These are the basic ones we would normally do for any child with recurrent abdominal pain. His stool for H. pylori came out positive, and there were no ovar or parasites in his stool. Local blood was also negative. Urinalysis was normal, but the abdominal ultrasound showed multiple discrete enlarged mesenteric lymph nodes, more in the right iliac fossa. Full blood count was essentially normal, except for mild anemia that he had, and his ESR was slightly elevated. So the ultrasound, the diagnosis was we're still thinking of PUD because of the underlying H. pylori infection, and we also thought of a mesenteric lymphadenitis. We actually screened him for TB, and this was negative. Well, I thought maybe this was because of a viral infection that he had a mesenteric lymphadenitis. So he was commenced on triple therapy, amoxicillin, clarithromycin, and omeprazole, which he had for 2 weeks. And on subsequent visits, the repeat H. pylori was negative, but he was still having this abdominal pain, and we decided to investigate him further. And we did a serum lipase. We asked for a serum lipase, actually, an abdominal CT scan, and it was also to have endoscopic evaluation. But however, he defaulted from the clinic, and we didn't even see him for up to 6 months. And 6 months later, he presented with 3-day history of right-sided abdominal pain, which was quite significant. And the abdominal pain was severe enough to disturb his activities. And at this time, the parents now opted to do our other investigations. The serum lipase was done, which was normal. And then the abdominal CT scan now showed us gut malrotation, which was really very strange. We were really surprised by what we saw on the CT scan. And this was, according to the radiologist, there was an inversion in the superior mesenteric vessels. The superior mesenteric artery is supposed to be on the left side, but it was found on the right side, while the superior mesenteric veins was located on his left side. And then the C part of the duodenum, which usually would cross the midline to the left side, was seen on the right side. So on account of this, we had to refer him to the pediatric surgeons, and he had the malrotation corrected. He had a LAT procedure, and he's doing so well now. And we've seen him in clinic, he's doing quite well. So these are just 2 cases of unusual cases of abdominal pain that we're not even expecting to see this diagnosis. And it shows us the variety of clinical conditions that can actually present with abdominal pain. And the essence of this discussion is to let us know that it's not all abdominal pain that is functional abdominal pain, because we know in 60 to 70% of cases, we think, okay, there may really be nothing going on. But with further evaluation, careful history taking, physical examination, and with current modalities of investigation, we can actually may be able to find the cause of the abdominal pain in some of our children. So as a matter of introduction, abdominal pain is one of the most common complaints we see in children. In fact, in our clinic, up to 60 to 70% of our consults are from abdominal pain. And sometimes it poses a diagnostic challenge owing to the variety of underlying causes that may be giving the abdominal pain. First of all, we need to know that the pain may be acute in onset, or it may be a recurrent or chronic abdominal pain. And the pain may actually be due to GI causes, or it may be from extra-intestinal causes. But the important thing for every physician attending to a child with abdominal pain is to identify those that have uncommon and potentially life-threatening conditions and that may require urgent evaluation and treatment. And we should also have in mind that many cases may actually also still may be functional abdominal pain, and may have cases that may be of organic or pathological pain in origin. And this concept of functional pain or organic or pathological pain is very important for us in GI because it helps us to know the approach to managing these patients. And usually we say when patient comes with abdominal pain and there are entities we call alarm features or red flags, you should think more of an organic or pathologic pain rather than a functional abdominal pain. But if there are absence of these alarm features or red flags, you should think towards more of a functional pain. And we'll discuss this later on in the presentation. Now, coming to acute abdominal pain, what are the definitions for, or how do we identify acute abdominal pain? Standard definition says it's severe pain of more than 6 hours duration in somebody that has been previously healthy, but it may require timely diagnosis, aggressive treatment, and may actually, in some cases, require surgical intervention. And other definition says the pain must have been going on in a non-traumatic setting with a maximum duration of 5 days. So we usually would look at acute abdominal pain starting acutely, severely, occurring at least for a period less than 5 days. Now, to classify acute abdominal pain, we have 2 main classifications. It could be urgent, it could be non-urgent. Non-urgent means that you need to intervene within 24 hours or even earlier than that, while the non-urgent pain may not require immediate treatment. Acute abdominal pain could be surgical and non-surgical, and it's very important for you as a clinician to identify those that are surgical, that would need surgical intervention, so that you can quickly refer to the surgeons before the child gets any further complications and which may lead to death. And in about 20% of cases, most series of acute abdominal pain have revealed a surgical etiology. So we need to be sensitized to this. And when I'm seeing a child with acute abdominal pain, the onus is on me to be sure that I'm not dealing with a surgical abdomen. And in terms of the causes of acute abdominal pain, we can look at it depending on the surgical cause and the non-surgical causes. So in this slide, I've tried to elaborate on the surgical and the non-surgical causes. Most of the surgical cases we see are mainly from appendicitis, intussusception. Sometimes we see intestinal obstruction, gallbladder stones we may also see in some of our children, especially in the teenage years. The non-surgical cases are mainly gastroenteritis, UTIs, mesenteric adenitis, Crohn's disease. Sometimes we may see acute hepatitis, or if the patient is a sickler, he may actually come in with one of the crises, an abdominal crisis. And occasionally we see DKA presenting with DKA patients presenting with abdominal pain. So this slide just illustrates the causes of acute abdominal pain based on age. And you can see for all ages, appendicitis is still on top of the list, followed by intestinal obstruction, and mesenteric adenitis, pancreatitis is also there. In the infant, it's always good to think about other things, especially things like infantile colic if it's in the first 3 months or so, intussusception, if there's history of passage of red currant jelly stool and all that, rotation of the gut. And in the older children, even some functional abdominal pain may present acutely, and we should also think of other things that may come to play. For example, if a female adolescent that I'm seeing and is sexually active, then things like pelvic inflammatory disease may also be considered as a differential diagnosis in that patient. Now, to evaluate a patient with acute abdominal pain, we must do a thorough history taking. And this means we must crack the abdominal pain thoroughly. We want to know about the progression of the pain, the location of the pain, which may give us an idea of the organ that may be involved. For example, if the pain is in the epigastric region, you start thinking of other things. Compared if the pain is in the suprapubic region, you know that the bladder is there, you think of UTI or some other condition. So the location of the pain is very, very important. Intensity is also important, and the character of the pain, like pain from intestinal obstruction, may be colicky in nature, and the pain may also be dull in nature. Like in our index patients, they basically had dull pain, and which was not pointing towards a surgical condition. The precipitating and relieving factors are also important. Associated symptoms are important, very important. You know, patient is having vomiting, is having abdominal distension, constipation. You need to think about an intestinal obstruction, especially when the vomiting is bilous in nature. The age of the patient can also be a key factor in evaluating acute abdominal pain. I've shown the slide previously of different etiologies or causes that you should think about depending on the age group of the patient. So recent abdominal trauma, previous abdominal surgery, may also be important in evaluating a patient that has acute abdominal pain. If the child has had previous surgeries, presents with pain, or develops adhesions, and this may be causing pains, that may be one of your differentials when you're seeing somebody that has had previous abdominal surgery. And a thorough review of systems is also very, very important. And generally speaking, the surgeons use this clue to help them, you know, especially in evaluating children that have acute abdominal pain. They will say if the pain occurs after a bowel movement, you should think about a colonic condition. If you have improvements in pain after vomiting, you may be thinking maybe the lesion or whatever you're seeing is in the small bowel. But sometimes this doesn't always follow. The important thing is to be sure that the patient doesn't have a surgical condition when they present with abdominal pain. Other clues says, okay, abdominal pain generally precedes vomiting in the surgical abdomen, but if it's a medical condition, the vomiting may precede the abdominal pain. But generally speaking, when you're seeing a child that has bilous vomiting, until otherwise proven, that child is likely to have intestinal obstruction. After a thorough physical examination, of course, our physical examination is very, very important. And the general appearance can also give you a clue to what may be going on in that child with acute abdominal pain. We know generally children that have peritonitis from any reason, usually they would resist, they want to have minimal movement. And when you want to even palpate the abdomen, they would give you a lot of resistance because they are in so much pain. And with peritoneal irritation, they like to remain still and resist movement. While with patients with visceral pain are those ones that usually would be writhing in pain, they may be restless and will be very uncomfortable. The vital signs are important. So a patient coming in with tachypnea, tachycardia, or hypotension, you know that child is already going into shock and has cold, clammy extremities, and you need to act very fast. The presence of fever will tell you that there's an underlying infection. Now, after doing your quick general examination, a thorough abdominal examination is very important in a child with acute abdominal pain. And the degree of abdominal tenderness, you should ascertain that. And rebound tenderness definitely will tell you that that patient has peritonitis. And you should also try and examine for masses or organomegaly, and all that. The bowel sounds also very important. When you are having a child that has distended abdomen with hypoactive bowel sounds, will tell you that, of course, this is likely to be intestinal obstruction. But at some other occasions, you may actually pick an hyperactive bowel sounds, depending on the stage at which you are picking your patients. It's good to examine the external genitalia in this patient, especially for young children that may have an obstructed hernia, inguinal hernia or femoral hernia. You may be able to pick up in these patients with acute abdominal pain. And a rectal examination is mandatory. Pelvic examination you would need to do in those that are sexually active, and especially when you have a high index of suspicion for a pelvic inflammatory disease. Now, after doing your thorough physical examination, there are some basic investigations that you would need to do. Of course, your investigations really will be determined by your history and your physical findings. So there are some generic investigations you may want to do when you're thinking about an infection. Your full blood counts will come to play. And when you're seeing fever, when you're seeing leukocytosis, anemia, all those may point to a bacterial infection if you have raised neutrophils alongside too. Urinalysis may be helpful, especially in patients that are coming with a lot of abdominal pain and have DKA. You may pick up ketones in the urine. And clean abdominal X-ray is very useful in patients that have acute abdominal pain, especially when you are suspecting intestinal obstruction. And when there is a perforation, you'll be able to see air fluid levels. You may see distension of the bowel loops and all that. So plain abdominal X-ray is quite useful for us. And then abdominal ultrasound, because it's readily available, doesn't expose the patient to radiation. You can also use that to evaluate your patient that has acute abdomen and to give you a lot of information. If you are seeing a child that has gallstones, for example, you'll be able to pick it up with the ultrasound. And if there's any fluid collection, any abscess, or any other thing, you may be able to see on your abdominal ultrasound. With further evaluation, if your X-rays and abdominal ultrasound have not given you a good yield, then you may have to go for more specialized imaging techniques. And that's where our CT scan of the abdomen and even abdominal MRI would come into play. And many of the radiologists actually prefer the MRI because it doesn't expose the children to a lot of radiation, even though many times we may not be able to do it because of costs. But when you need further evaluation of what is happening in the abdomen, the imaging technique to go for is either a CT scan or your MRI. Now, this is an algorithm to help us just to put into context a patient that has acute abdominal pain. So a patient comes in with a lot of pain, it's less than 5 days. You want to look at the patient. Is the patient very ill, frustrated, and is having deranged vital signs? You do an abdominal X-ray and you're thinking, okay, this child may have intestinal obstruction or any of the surgical complications, then you need to call in your surgeons, And if, as I said earlier on, there's bilious vomiting, distension, that should strengthen the suspicion of an obstruction, and you should also call in your surgeons as soon as possible. And if a patient comes with jaundice, then that may change your picture, and you may need to look at the hepatobiliary system, especially when the pain is in the right upper quadrant or even in the epigastrum. Then you may need to, and you're having hepatomegaly, nausea and vomiting, you may need to look at the hepatobiliary system and do the liver function test, serum amylase, especially when the pain is radiating to the back. You think of the pancreatitis, and do serum amylase and lipase and your appropriate imaging, and you may be able to make a diagnosis of acute pancreatitis or cholecystitis, and rarely see cholangitis. But pancreatitis and cholecystitis are things that you should think about, or even acute hepatitis too. When a patient comes with abdominal pain and jaundice. Now, having talked about the acute abdominal pain, we'll now focus on the recurrent abdominal pain. Other people refer to this as chronic abdominal pain. And many times we say in GI circles that it can be a nightmare. It's a nightmare of the gastroenterologist to know why this child has been having this pain recurrently. It's not of surgical origin, but the pain keeps coming back. How should you evaluate this child with recurrent abdominal pain? So many times recurrent abdominal pain in the past has been described as functional abdominal pain. And in 1958, a British pediatrician, actually John Apley, described this pain as being pain that using the rule of threes. That is a pain that occurs at least 3 times. You're having at least 3 episodes of this recurrent pain, is intermittent, and is severe enough to disturb the activity of the child. And it must have been there for at least 3 months. And usually there's no evidence of any underlying inflammatory, anatomic, metabolic, neoplastic condition to explain this pain. And in previous years, we've said that recurrent abdominal pain of functional origin, in 90% of the patients, you cannot find an organic pathology. But a lot of things have been changing with modern investigation techniques now, that even so, those pains that have been referred to as recurrent abdominal pain, functional origin, with modern techniques, we are beginning to discover that some of them may actually have some pathology that was previously discovered. But nowadays, because of semantics and changes in terminologies, most functional GI disorders are now referred to as disorders of brain-gut interaction. Because in those ones that you evaluate thoroughly and there's no underlying pathology and the patient is feeling the pain, we have found that it's basically because of perception problem. There's a sort of abnormal communication between the brain and the gut, whereby the child is actually perceiving a lot of pain in the gut and in the GI system, whereas there's no organic pathology to explain this pain. The epidemiology of RAP has also changed, and the trends have shown that a lot of things have changed concerning the epidemiology. And in a recent study in Sri Lanka, 23% of the affected children who were originally thought had functional abdominal pain were now noticed or observed to have some organic diseases. But generally speaking, we know that this functional abdominal pain, or what we now call disorders of brain-gut disorder, disorders of brain-gut interaction, usually there will be no organic cause for it. And it's also known that sometimes it can even coexist with some other pathological condition. One of the take-home messages from this presentation is disorders of brain-gut interaction, or if you call it functional abdominal pain, is a diagnosis of exclusion. You must be sure you have thoroughly investigated that patient before you say this patient has a functional abdominal pain. This functional abdominal pain or recurrent abdominal pain of functional origin usually affects 10 to 20% of school-age children and tends to occur commonly between children ages 5 to 14 years. So we rarely see it in children below the age of 5 years. It's responsible for almost 40 to 60% of the referrals to the pediatric gastroenterology clinics. In terms of sex predilection, it happens to be more common in girls than in boys, though we don't know the reason for that, really. The risk factors that have been identified for many functional abdominal pain include psychological factors. So if there's been conflicts in the family, death, domestic violence, parental loss, economic stress, or the child is experiencing bullying in school, they may actually develop and start complaining of abdominal pain. Child abuse should be excluded, any form of child abuse, parental anxiety, and in patients that have autism, that have attention deficit hyperactive disorder, for one reason or the other, the functional abdominal pain tends to be common in them. Now, in terms of etiology and classification, recurrent abdominal pain, as I said, can be divided into the functional ones and the ones that have an organic pathology. And those that have organic pathology, you need to investigate them. You want to know whether is it from a GI cause, or is it a hepatobiliary problems, or is it a urinary tract problem, or is it a gynecological problem. Well, for those that have functional disorder, usually we would describe them using the Rome criteria, and I would explain. Well, we are still going to talk a lot about the Rome criteria, because it's a criteria that has helped us to actually identify and tease out patients that have functional disorders that would result in recurrent abdominal pain. Now, what are the organic causes of recurrent abdominal pain? The GI causes, I have listed them here. Maybe from lactose intolerance, but to make this diagnosis, you take a good history. And taking a good history may help you to have different differentials for the organic causes of the recurrent abdominal pain. So they include lactose intolerance, gastroesophageal reflux, Helicobacter infection, which may lead to peptic ulcer disease in the long run, and gastritis, inflammatory bowel disease, and so on and so forth. And the urinary tract causes are also listed here, ranging from urinary tract infection to obstructive uropathy, hepatobiliary causes, and then the gynecological causes. Now,
you have 10 minutes more.
Okay, sir. I will go through that, sir. Just to say a few things about the pathophysiology of the functional abdominal pain. Usually, it's because they don't have an organic problem, but due to early life events or abuse, they may have visceral hypersensitivity and hyperalgesia, and may develop motility problems and immune dysfunction, which when there's alteration of the gut microbiota, you have release of serotonin, and which stimulates pain nerves in the abdomen. Rome criteria, I mentioned earlier, it's very important, and it helps us to distinguish the type of functional abdominal pain disorder that we may be dealing with. And the current one we are using now is the Rome 4 criteria. Now, the tips on the Rome criteria that helps you to identify patients with functional abdominal pain is: number one, in those patients you don't have alarm features. Most functional abdominal pain are usually periumbilical, sometimes in the epigastric region, but the rule of thumb is when the pain is away from the umbilicus, look for an organic pathology. And the main classification pain syndromes that come under the functional abdominal pain, and if the pain is in the epigastric region, think of a functional dyspepsia. If the pain is in the periumbilical region and is associated with change in the bowel movements, either constipation, diarrhea, or you have an alternative constipation or diarrhea, and you think of irritable bowel syndrome. If you have periumbilical pain that's associated with migraine headaches that look like migraine, nausea, vomiting, and photophobia, then you think of abdominal migraine. And if you have pain that doesn't fit into either abdominal migraine or irritable bowel syndrome, then you should think of the functional pain otherwise specified. So this just to illustrate the Rome 4 classification, for functional GI disorders. And as I said earlier on, irritable bowel syndrome and the others are highlighted there. So with the Rome 4 criteria now, the teaching is that you don't have to wait till 3 months before you say this patient has recurrent abdominal pain. If the patient is having pain up to 4 times in a month and up to 2 months, then you talk about recurrent abdominal pain. I think I'll skip most of all this. We can always check up on the criteria for irritable bowel syndrome and abdominal migraine in our spare time. Now, in the management of patients with recurrent abdominal pain, you go through the history, we've gone through the pain history, but the important thing for you to know is that those patients don't have alarm symptoms. They don't have alarm symptoms. And what are these alarm symptoms that we're talking about? If you have a patient that has recurrent abdominal pain and has any of these features highlighted in this slide, dysphagia, poor growth, GI bleeding, significant vomiting, unexplained fever, involuntary weight loss, you should think about a pathological thing. This is no longer a functional abdominal pain. Once you are seeing these red flags or alarm symptoms. So for all our patients that are coming with recurrent abdominal pain, we will do these basic investigations. I've mentioned them earlier: stool examination, screen for H. pylori, do abdominal ultrasound. If you do those three and there are no abnormalities, and you check your urine, there are no abnormalities, and if there's a need for you to do endoscopy, you will do it, and there's no problem, then you can confidently say this patient has recurrent abdominal pain of functional origin. So this study is just illustrating our findings, in the endoscopy unit in patients that are presented with recurrent abdominal pain, and some of them had gastritis and gastric erosions. And we found that endoscopy is actually very useful in evaluating patients with recurrent abdominal pain. Now, coming to the treatment of recurrent abdominal pain, talking about functional pain now, this is not organic pain. It requires a multidisciplinary approach, and you may involve the gastroenterologist, your dietitians, and social worker. And the three main approaches is to do dietary intervention, non-pharmacological therapy, and pharmacological therapy. So this is an algorithm showing what we do. If you have done lifestyle and dietary intervention, it doesn't work, then you now consider whether you do your non-pharmacological or pharmacological therapy. So the dietary intervention that has been found to be very useful for us is what we call the low FODMAP diet. We know that this refers to fermentable oligosaccharides, disaccharides, monosaccharides, and polyenols. And we know that all these fermentable sugars causes a lot of abdominal pain and bloating. So patients that have functional abdominal pain are put on this low FODMAP diet, and it appears it's quite useful in some patients. Other diets that have been tried are the low lactose, low gluten, and low fructose diet. And meta-analysis in literature have shown that the FODMAP diet, low FODMAP diet, is actually very useful in reducing pain syndromes in patients. Some other workers have looked at fructose, low fructose or restricted fructose diet, and they found that that has also been very useful. Other foods that should be eliminated in the diet that has been found to be beneficial is what we call the 3 C's: chocolate, caffeine, and cheesy and fatty foods, which all cause release of short-chain fatty acids and causes a lot of bloating. So we try to tell our patients to avoid this in their diet and to remove spicy foods, avoid NSAIDs as much as possible. Use of fibers has also been quite useful, and it works the way the probiotics, the prebiotics work, and it's been found to be useful in some of our patients. So the use of probiotics also has been found to be very useful in reducing pain from functional GI disorders, especially those ones that have lactobacilli and bifidobacteria. And in this study that was conducted in Italy, the evidence showed that when you combine your symbiotics and in patients with IBS, when you give symbiotics, probiotics is actually very useful in reducing pain. The non-pharmacological therapies include what we call behavioral therapy, and include things like hypnotherapy, cognitive behavioral therapy. And the essence of this is to distract the patient, help them to get involved in muscle relaxation techniques that will help to reduce the perception of the pain. And in many centers, this has also been found to be quite, to reduce the episodes of pain and help the coping ability of the patients with the pain. But our limitations with using this therapy is that you need a lot of therapists. In children, the evidence is still is not conclusive yet, and we need multiple sessions. So those are the limitations in using many of the behavioral therapies. Now, if the behavioral therapy and your diet doesn't work, then you may need to go on to the pharmacological therapy. And what has been proposed are the antispasmodics, peppermint oil, which help to reduce the muscle spasms in the colon, and the grutaveran, nebiveran, all these are also antispasmodics that have been found to be useful. They act on the smooth muscles and may relieve pain in patients that have irritable bowel syndrome, for example. And when you do a combination of some of these therapies, peppermint oil with antispasmodics, with probiotics, a combination therapy seems to work a lot more rather than single therapies. And this was what was seen in this randomized placebo-controlled trial that was done in India. A combination of all the antispasmodics and the probiotics was very useful. Let's see this. Now, antidepressants may be your last resort if your dietary therapy, behavioral therapy, and antispasmodics have not been found to be are not useful. And the use of amitriptyline in adults has been found to be quite efficacious. In children, there's still few studies that have looked at this, but citalopram has been found to be useful in some children and adolescents, but still require further studies. Now, for abdominal migraine, for example, cyproheptadine and propranolol has been quite useful in children. Cyproheptadine in children below 5 years and propranolol, which is a beta blocker, has been found to be useful in this group of patients. And that is being proposed now. Other drugs that have been found to be useful are for functional dyspepsia. We can use our PPIs and other anti-reflux agents. For those that have constipation, especially constipated IBS, we can use laxatives, which may also be useful. Antibiotics are not useful in the treatment of recurrent abdominal pain, and sometimes even placebos may be useful in some patients. So, in conclusion, I would say abdominal pain, our take-home messages is that abdominal pain, it could be acute or recurrent, and this dichotomy should be recognized by attending physicians and may help you to unravel the diagnostic dilemma. Management of acute abdominal pain should be aggressive, and you should always keep it at the back of your mind that you may be dealing with a surgical case and call in the surgeons as soon as you are able to unravel this. The approach to recurrent abdominal pain is that, is it an organic pain or a functional pain? And when you're seeing alarm features in a patient that's having recurrent abdominal pain, please think about a pathologic pain rather than a functional pain. Treatment of functional abdominal pain requires multidisciplinary approach. We start with our dietary intervention with the help of our pediatric dietitians, and sometimes this may work in our patients. And if it doesn't work, then you go to you try out the other modalities of treatment, the non-pharmacologic behavioral therapy or your pharmacologic options. So pharmacological options and placebo-based interventions should be attempted when the non-pharmacological options fails and is not efficacious. So I think I'll stop there. These are my references, and I would go on to take any questions or clarification. Thank you very much.
Yeah, thank you very much, distinguished speaker, Dr. Olufunmilayo Adeniyi, for that beautiful, very lucid, very clear presentation. Thank you very much. Abdominal pain is a very common complaint, but we've been shown now that it's a very wide and interesting topic. Just one or two things, just a brief summary before we take the comments. What she has told us, just like, to remind us, she started with two good illustrative cases just to highlight the importance of these cases because they are common causes of this abdominal pain. the Crohn's disease, which we in the past used to think it doesn't occur in our environment, but at least cases are being seen now. And then the second case, that of recurrent abdominal pain, we turned out later on to have been caused by malrotation. Then he went on to elaborate more on the entity referred to as RAP, recurrent abdominal pain, or which many now refer to as chronic abdominal pain, which again is an interesting one. Unlike the acute causes of acute abdominal pain that you have to aggressively treat, this one can be a real problem. She gave us the definition, the rule of three episodes, at least in the first 3 months or over, but then this has also changed. And then the fact that many causes of this recurrent abdominal pain are organic, more or less like functional, but then we must always be on the lookout, have that high index of suspicion for the possible severe cases that will have to be, aggressively managed. Some of these surgical cases or some of these inflammatory causes, like the one that was presented, that of malrotation. Okay, she will also, on one of our slides, showed us some of these red flags to be on the lookout for, when we are confronted with cases like these. And then she went on to the investigation. To manage cases like this, you need a very detailed history and thorough physical examination. And initially, maybe minimal investigations. But then you'll be directed as things go on. Detailed history, physical examination, the stool very important for overall parasites, for any blood in the stool, and sometimes the culture, and then abdominal ultrasound also important. And then you take it from there. But where we have any red flag, then that can guide a direction of management, and then we'll go on to more investigations. Now with the treatment, well, she alluded to room 4 criteria, which we won't go into at all. Then the treatment, we're told, is it's multidisciplinary, particularly for the functional cases. In other words, this will involve, other specialties, the dietitian, the pediatrician, the gastroenterologist will be involved in many of these cases also at this stage. And then the role of the low FODMAP, the fermentable feeds, also mentioned. And she also mentioned some, the non-organic, non-pharmaceutical management involving the behavioral or cognitive management, and then the pharmaceutical ones. And she mentioned some of these drugs also. But the by and large is you need that high index of suspicion and oftentimes exclusion. You must try to rule out the causes of organic cases before you can then finally be rest assured that what you are dealing with is a functional cause of recurrent abdominal pain. I think because time is far gone, I will stop here and then take comments. I think we'll take comments for maybe 10 minutes. We can't take comments or questions now for 15 minutes because time is far gone, but I will allow 10 minutes of grace for comments and questions. Thank you very much again.
There are some comments in the chat box, sir.
Yes, I can see them. The first one by Dr. Edem Duke, he wants to know for how long the triple therapy should be given to a child who is H. pylori positive. And I thought I saw one other one. The other one is just great presentation, excellent presentation. There's another one which I can't find again now. Okay, please, if you can take the first one.
Sir, the other ones are indications for endoscopy.
Oh, okay.
In a child with recurrent abdominal pain.
I saw it before, but I can't find it again. Okay, please, anyone you see. All right, so we have those two to start with, please. Dr. Adeniyi.
Yes, sir. Okay, thank you very much, sir. Thank you, everyone, for your attention. Triple therapy, as we know, is for treatment of Helicobacter pylori infection, and there are different regimens that have been proposed. But the one we commonly use is the therapy that has amoxicillin, clarithromycin, and omeprazole, and that has been found to eradicate the H. pylori in up to 80% of cases. And this should be given for 10 to 14 days. And sometimes, if the patient has a lot of abdominal pain and all that, we may extend the treatment, the omeprazole component of the treatment for 1 month. But generally speaking, the triple therapy should be used for 10 to 14 days. 2 antibiotics, namely amoxicillin, clarithromycin, and omeprazole. In some cases, that's usually our first-line therapy. But in a case where you are not able to eradicate the H. pylori with your first-line therapy, then you can go on and give your second-line therapy, which is usually levofloxacin, a quinolone-based therapy, levofloxacin, clarithromycin, and omeprazole. But the omeprazole ideally should be given for 2 weeks. But if I'm seeing a patient that maybe I've done endoscopy for the patient, is H. pylori positive, I'm seeing a lot of ulcers or gastritis, I may extend that omeprazole therapy for up to a month. But the ideal treatment is for 10 to 14 days. I hope that answers this question. Then the second question is on indications for endoscopy in children. And that's an excellent question. It's a very good question because it's not all abdominal pain that you would need to evaluate with endoscopy. And the rule of thumb or the teaching is that any patient that has an alarm feature, you should send for endoscopy. So if I'm seeing a patient that has abdominal pain, is losing weight, is having poor growth, and there's no other explanation for that, I would scope. GI bleeding is an alarm feature. Any child that comes in with GI bleeding, I would go ahead and I will scope the child. If the child has poor growth, if the child has any other alarm feature, I would do endoscopy for that child. But in some cases, if the abdominal pain has been going on for a long time, chronic abdominal pain, for example, like 2 of the cases we saw, they have been having this issue for up to a year. For those kind of patients, because of the duration of the symptoms, and if there is also an alarm symptom, I will still go ahead and I will scope the child. So we actually individualize, okay? The alarm features are the general indications that, okay, if compulsorily, I need to scope this child. But if I evaluate the child and the duration of the symptoms has been so long, the child isn't getting better on whatever therapy I'm giving, I may decide to scope the patient. So that's in that case, in some cases, you may actually depend on your index of suspicion and individualize the indication. But generally speaking, any patient that comes in with alarm features and abdominal pain, you should refer for endoscopy.
Thank you. There's another question which I've just seen now on the chat by Dr. Elizabeth Onifade. she wants to, I mean, she said it will appear that chronic constipation with overflow is not common in Nigerian children. Is this diet related?
Okay, thank you very much, Ma, for that question. Well, we do see some cases of chronic constipation in the clinic, but they are not very common. They are not, as you have said, they are not common. It may be related to our diet in some way because many children, when they are taking their swallow or even rice, they take some sort of vegetables with it. Many of the swallow diet, for example, at least we take, children will eat it with either okra or ewedu. So there's some sort of vegetable in our diet for those that take swallow. Even nowadays, many children, when they're eating rice, most enlightened parents will say, okay, I'm not giving you just plain rice. I might put some carrots and some other vegetables alongside. So that helps because of that quality of fiber in our diet and intake of vegetables. I think it helps with the bowel motions in many of our children. But occasionally we do see patients that have constipation, and when you interrogate them further, you find out that those ones are those that have low fiber diet. They are not taking enough fruits and vegetables, or they are not taking enough water when they eat. And those are the ones that would really come down with the chronic constipation of functional origin. Occasionally we see chronic constipation that may be pathological, but those are really very far in between. We rarely see them. Maybe the child has a polyp or a mass and has chronic constipation. Those are really very rare cases. But most of the constipation you see are diet related because the children are not taking enough vegetables or fruits or have low fiber in their diet. Thank you very much, ma'am.
Thank you very much. I can't see any other question or comment on the chat.
Hello.
Yes, please.
Good morning. I have my hand up. Professor Grange.
Oh.
Please go ahead, ma.
Good afternoon, ma, or good morning over there, ma.
Good morning here. Thank you very much. I've really enjoyed Dr. Adeniyi's presentation. Adeniyi's presentation. It was a marathon one, very comprehensive, and will be very useful to residents because it's a very common question that is asked for residency in the residency program. No, I'm making comments, first of all, to say that to register my presence as one of the founders of the association. Yes. Secondly, to make a couple of remarks concerning the clinical challenges that the family doctor has with abdominal pain in young children. In order to distinguish between the organic and functional, I have often found that the presence or absence of appetite is also a good indication. You know, I don't know whether you have found that. Secondly, there's often a problem with locating abdominal pain. Yeah. And particularly, you're trying to locate the tender area. It's often very difficult with children.
Yes.
So maybe you just make a comment on that. The location, of course, because the child is unable to actually locate the pain in the abdomen, the pain may be due to inflammation in other areas, such as otitis media in the very young child, upper airway infection, and even meningitis. So, you know, these are things that the family doctor has to consider before the child is parceled off to an expert like you. So thank you very much, Dr. Adeniyi, for that very beautiful presentation. You've worked very hard on it. And we have confidence that when we fail to make the diagnosis at the clinic level, we can rest assured that when it gets to you, you will solve the problem. Thank you.
Okay. Go ahead. You want to comment?
Yes, sir.
Okay, go ahead. Then we'll.
Thank you very much, mommy. Thank you very much, Professor Nikegrinch, our founding mommy. We thank you for your comments and for making out time to attend this webinar, ma. We appreciate your presence. Yes, ma, I agree with you on the comments on the appetite, because truly, if a child doesn't take enough, then they are not likely to make enough stools, and they may actually get constipated. So the issue of appetite also has a huge role to play in bowel movement for many of our children. And I totally agree with you, Mark, that a child that has reduced appetite, that is not taking enough, will probably get constipated along the line. Also, in the terms of the location of the pain, in fact, that is a huge problem in children, especially children below 5 years. They can't tell you where they are having pain. They just know that they are having pain. And they will, if you palpate the epigastrium, ask them, do you have pain there? They will say yes. If it's the suprapubic region, they will tell you everywhere is yes. So sometimes you really have to have a good clinical suspicion of what is going on and rely on the history given to you by the parents and your own clinical acumen to help you to know exactly where the pain is and what is actually wrong with the patient. So that's one of the limitations we generally have in pediatrics, even the older children. So sometimes they poorly localize pain. And so that may be a challenge every one of us has to face. In terms of referred pain, and I think that is also another reality, because we may have a patient that even has a pneumonia and may have referred pain to the epigastrium, to the lumbar region and all that. That is also something to also equally consider. And look at the child holistically and know, am I dealing with, is this pain primarily originating from the abdomen, or is it a referred pain from elsewhere? Is there some irritation in the diaphragm that the child is having this pain from and all that? And with careful and meticulous history-taking physical examination, and with your investigation, at the end of the day, you may be able to make an accurate diagnosis in the child. Thank you very much, Ma. Thank you for your comments and questions.
Thank you very much, Ma, for your comments and questions, and thank you, Dr. Adeniyi. If I may just add one or two, from my own experience, what I used to do then when I was in UCH, because I used to have many of them then, not where I am currently, is, as the speaker said, pain location, yes, can be difficult, but I try to distract them. You try to distract them and ask them to point with the finger where they really feel the pain. And when you now palpate that same spot, distracting them, you will find out there's no tenderness or anything as such. But even this still doesn't completely rule out an organic cause. But in most cases, with my own experience, I then pick up many of these functional cases, particularly those beyond the age of 5. And I want to share one experience before I hand over to the coordinator. When I was some years back in UCH, I had this patient, the daughter of my vet doctor, very close to me, and then he then brought this girl. I think it was in maybe GS1 or GS2 then, in Orita Mefa, secondary school, close to UCH there. Complained of abdominal pain. I examined, did everything I knew. I concluded it was functional. But some months later, she came back with vague complaints. Now we then suddenly faint and we rush to the emergency room from Orita Mefa. I then involved, and then with abdominal, with chest pain, with the abdominal pain, I involved the cardiologist. We did everything just to be sure. Still nothing. Then he started faking even convulsion. She'll be rushed back to emergency room. I had to then involve Professor Lagudu now. We did the EEG, everything. We admitted on Northwest too. But it was still deep down in my mind that most like, I still feel this is functional. Very intelligent girl. So we admitted on Northwest too. Of course, unfortunately, I had a program in Abuja that I had to travel to Abuja for one day. I asked that consultant to look in, and then the senior registrar. But immediately I landed in Lagos, I called to find out what was happening. With the, again, they found non-specific EEG changes. So they said, okay, maybe just place on one, I can't remember which of these convulsants we placed out. But when I arrived in Lagos, I just called, and because I had not been called. And this was a girl before I left, they said was having convulsion, episodes severally. So I called and said, look, there is nothing wrong with this girl. Stop that anticonvulsant and come. In fact, the residents were shocked. I said, I'm very sure, stop it. And I drove down to UCH. And when I got there, they had a different story for me. Completely different story. This was now a girl before they got to her during the morning ward round on that day, the residents had discussed something about her before coming to her. And as soon as they left to, get to her bed, as usual, she started convulsing again. And then came round without anything being done. But all the questions they asked her, based on what they had discussed, she answered them. So I then got in, and the matron who did night called me to one corner and said, Dr. Akimbami, this girl is faking all these symptoms. Apparently, in the night, the nursing staff on night duty just engaged her, and they were going around together dispensing the drugs. And now suddenly told her, you know what we are doing now? I did it to my dad. And she said, are you sure? Really? And that was how everything broke up. She said, yes, because she knew that her daddy loved her more than the mom, and you wanted that to continue. So we just called the parents, took them to one corner, explained everything to them, and then called her too and broke the news to her. And then she started apologizing, begging, and said, well, this is not. But she could have caused even an accident because she faked a convulsion when the whole family was coming back from Lagos on that long bridge. And the father, looking in the mirror, saw her convulsing on the rear seat and almost lost control. So this is just to say that, recurrent with the functional abdominal pain, particularly in those so-called intelligent girls. And this girl is very brilliant. She was reading even medical books and was always ahead of us, one step ahead of us. But eventually, she got to the end of it all. So this has been an interesting session. And again, I must thank the speaker and the entire members of the Guild of Pediatricians in the Private Sector for this webinar. Thank you very much. So I hand over now to Dr. Letu. Hello?
Yes, sir.
Oh, sorry, I thought I was talking to myself, sorry. Thank you very much.
Not at all, sir. Thank you very, very much, sir. And Dr. Adeniyi, a very big thank you as well.